Ar-Rahman Ar-Rahim. First of all, I would like to thank the organizing committee for inviting me and my colleague, Dr. Mahmoud Al-Zar'i, to chair this session. Dr. Mahmoud Al-Zar'i, my colleague, is a consultant endocrinologist from Doha. I am consultant endocrinologist from Dubai, United Arab Emirates. I will start with presenting our first speaker of the day, Dr. Tamer Al-Isa. He's consultant in endocrinology, diabetes and metabolism at Jabir Al-Ahmed Hospital in Kuwait. Dr. Tamer Al-Isa topic will be choosing first injectable therapy. Dr. Tamer.
Good afternoon, everybody. Thank you for the kind introduction. I was speaking to you about choosing the first injectable therapy in patients with type 2 diabetes. These are my disclosures. So it's well understood that we're facing a global pandemic, actually also with diabetes. We're expected to increase in the level and the prevalence of type 2 diabetes significantly in the next 30 to 40 years. In the Middle East and North Africa region, we're with the second largest increased prevalence around the world and expected in the next 30 to 40 years. We're expecting almost 100% increase in the prevalence of diabetes. That creates a lot of burden in the management of such condition. In the MENA region, expected from the IDF, from the 9th edition Atlas, that the prevalence of diabetes is expanding, and in the region of the North Africa, especially on the east side, Middle East, in the Gulf region, and also the surrounding area, showing its prevalence of diabetes is more than 13%. And in some local data, also especially in the Gulf regions, they are the leading prevalence of diabetes, up to 25% of the country. We understand definitely with this large population of diabetics, we kind of face an issue with trying to control diabetes. These are all data about the average HbA1c control in type 1 and type 2 diabetes in the Middle East. We're not really much different from other regions in the world. The mean of HbA1c is 9.6%. That's all data, probably has some changed, but still, we still have a problem in trying to control our patients and get them into the right appropriate levels of diabetes control. We understand from the UKPDS is that as years progress, when patients having type 2 diabetes, the beta cell function, and this is an estimation percentage by HOMA, is that the percentage of beta cell function actually declines. So 6 years after the diagnosis of diabetes, more than 50% of patients required to be on insulin therapy to reach the target of fasting plasma glucose of equal or more than 6 millimoles. That creates a lot of burden in terms of management. Injectable therapies has to be introduced at the right time and to get the patients to prevent their complications. Starting injectable therapy for type 2 diabetes is very important to decide to add on or to decide when to do the switch from an oral to injectable therapy, and we need to do it at an appropriate time. The decision to start injectable therapy can be made in case of suboptimal control, or if there is one or more oral anti-diabetic, in case with one or more oral anti-diabetic medications, that's the right time to think of doing injectable therapies. But we have to be careful that we should not really delay when we intensify the therapy to injectable therapies. There's a lot of clinical inertia that pushes therapy forward. This is data from Professor Conti and his group looking at a number of years it took patients from having an uncontrolled diabetes HbA1c value and how many years it required them to progress to additional therapy. For a patient on a single oral therapy, it requires about between 2 to 3 years until adding a second agent, oral agent. Patients on 2 oral agents requires up to 7 years until adding a third agent. And also the first injectable therapy as an insulin, it's required about 6 to 7 years from 3 oral therapies with uncontrolled diabetes. So it can control their diabetes. So, and even premixed insulin or any additional therapies will also require further years to control that, to introduce these kind of therapies. So it's a very significant delay with that. Also, time to treatment intensification is very important. We need to do it also early. This is data from the UK Clinical Practice Research Data Link, is that when there is actually a delay in introducing appropriate therapy, an intensification of therapy to get diabetes under control, actually we can increase the risk of developing microvascular complications of diabetes. Here they looked at the several of the cardiovascular risk or complications related to diabetes, looking at the MACE here as an outcome, and looking at the red bar, which is the delay in intensifying therapy beyond 24 to 36 years. It increases significantly the prevalence of incidence of developing of MACE in diabetic population. So what can we choose as an injectable therapy for type 2 diabetes? Definitely there's the basal insulin, GLP-1 receptor agonist, premixed insulin and co-formulation insulin, we'll talk about that later, fixed ratio combination between basal insulin and GLP-1, which is a new molecule has been used recently, and also the typical basal bolus insulin therapy. Factors to decide on when to start injectable therapy could be because of presence of comorbidities and complications related to diabetes, the glycemic control, contraindications to certain use of some injections, the BMI of the patient, the tolerance of the therapies that we can use, the risk of hypoglycemia is important also, especially with the insulin therapies, and the cost definitely is how to afford all these injections. Of course, the GLP-1 receptor agonist comes very well understandable that they have shown significantly improvement or reduction of the cardiovascular outcomes in several of the trials. So this is the meta-analysis looking at the MACE outcome in all the known or the published so far the cardiovascular outcome trials. This is led by the first trial that was published, which was the LEADER trial, showing significant reduction in MACE outcome, followed by the SUSTAIN and also the HARMONY, and then the newly presented study, which was the AMPLITUDE. There are other trials that have not shown a clinical significance in reducing cardiovascular effect, but as a meta-analysis, there's an odd ratio of all these therapies together can help in reducing MACE outcome is 0.86, that's about 14% reduction. How GLP-1 could be helpful in that? In the myocardial effect, GLP-1 receptor agonists can cause vasodilation in the vessels, in the myocardial arteries itself. They can reduce inflammation in the myocardium itself by reducing inflammatory cells, cytokines and chemotaxis, and also can improve myocardial handling of glucose, improve energy efficiency, and with that can improve the cardiac function. In the systemic effect, it can reduce adipose tissue because it can help with weight loss. It reduces gluconeogenesis, so it improves glucose metabolism, and can cause vasodilation, reduce blood pressure and reduce atherosclerotic lesions in the blood flow. That's why we see the effect mainly on strokes and ischemias. So with that, we can actually improve and prevent or improve the cardiac function. So no wonder now, with the newer guidelines being developed, is that where there is a dedicated part for patients who have type 2 diabetes or diabetes generally and develop atherosclerotic cardiovascular disease or very high risk to develop such complication, is that the main recommendation for therapy, even if they have a normal glycemia, a normal diabetes control, it's recommended to start them on a GLP-1 or SGLT2 as an oral therapy. But this is very understandable because of the cardiovascular outcome trials that show significant benefits. Also important to mention is that in terms of choosing a therapy, an injectable therapy to improve diabetes, the injectable forms of diabetic therapies have a significant ability to reduce HbA1c and get patients under control. GLP-1 on an average can reduce A1c somewhere about 0.9 to 1.3%. Insulin is different because of the different types of insulin being used, whether it's basal, rapid acting, or a combination of the two. So there are levels of A1C reduction doesn't really have a maximum level, but it depends on what's in the studies have been shown. The A1C reduction could be up to 2.5%, but we understand since this is an insulin injection, there is actually there is no limit of how much A1C you can reduce with insulin. This is a nice study, was published in 2019 in New England, looking at what would be a good choice to start in terms of insulin in patients who are type 2 diabetic, insulin naive, and they have an uncontrolled diabetes with an A1C of between 7 to 10% on a maximum oral doses of oral therapies. So here there was three choices that patients were randomized to, either to give them biphasic insulin, so a combined intermediate acting with a short acting, rapid acting insulin, brandial insulin only without a basal, or give them only basal insulin. So this is the amount of A1C reduced in this trial. So the lowest A1C reduction was with the biphasic and the brandial insulin. The least A1C control, or the level of A1C, was with basal insulin. So there is, you can see how much with biphasic especially, you can actually, since it's a standard therapy, you can actually get patients into or improve their diabetes control. But the problem is that with the side effects of these therapies, this is the rate of hypoglycemia. There is a significant high levels of hypoglycemia that happens with biphasic insulin and also with brandial insulin, but very minimal with basal insulin therapy. So even though you might get a slightly less effect on reducing A1C, but you're actually having less hypoglycemias. Also, in terms of effective body weight, patients who received either brandial or biphasic, which also included a brandial insulin, they have the highest levels of weight gain compared to basal insulin, which has the lowest amount of weight gain. So this is was also one of the reasons why the initial injectable therapy in the 2000s was starting insulin therapy. And insulin therapy, generally the basal, like especially glargine, been used as one of the most important therapies for many years worldwide. And that's because of its effectiveness in getting patients into target fasting plasma glucose. In terms of consistency in the A1C reduction, regardless of what's the background therapy of the patient and what's the other therapies he's using. And also patients reaching targets, it shows a significant levels. This also data showing at the how much percentage of patients reaching the target of less than 7% as they progress from 12 weeks to up to 24 weeks, almost a little bit more than half of patients get into the target of less than 7%. And insulin dose also definitely increases with that as you increases the dose to get patients under the control. Definitely because it's the insulin anyways, you will face the trouble of developing some hypoglycemias. And this is also was observed throughout the use of glargine therapy, whether it's an overall hypoglycemia or even nocturnal hypoglycemia. But very minimal severe hypoglycemias were noted. Glargine also looked at cardiovascular outcome in terms of safety, the ORIGIN trial, and it showed compared to standard therapy that insulin glargine is safe and does not really increase the risk of developing cardiovascular disease. Newer agents of therapy of basal insulin have been shown to be effective as a first injectable therapy in patients with type 2 diabetes not controlled on oral therapy. This is trials of glargine U300, which is a newer generation of glargine therapy. This is compared to glargine U100, which is the standard glargine therapy. In the edition 3, they compared both those two agents, glargine U300 versus glargine U100, in patients who are insulin naive, uncontrolled diabetics on oral therapies only. So they tried to choose which would be the best option to start patients as a first injectable therapy. In terms of A1C reduction, it was similar in terms of effect. There was no difference between the two agents. They both had improved the A1C significantly at the same level. But what's the difference between those two agents is that with glargine U300, there was less risk of developing hypoglycemia because of the longer duration of glargine U300. And that's probably was one of the reasons to help reduce the events of hypoglycemia. So nocturnal hypoglycemia was 30% less, and anytime hypoglycemia was 14% less, and that was significant in both groups. Also, newer generations of basal insulin was the degludec, and was also tested in patients who are insulin naive patients on oral therapy and they are not on the right control. And they tested that against the standard therapy, which is glargine U100. And in this trial, looking at the core trial up to 52 weeks, there was no difference in A1C reduction. Both of these agents have controlled diabetes well and reduced A1C at the same time, at the same level. And even on an extension period, there was no difference in the amount of A1C reduction. So both agents behave the same in terms of efficacy in reducing and controlling diabetes. Similar here what we saw before, because degludec is a much longer duration of insulin therapy. Comparing degludec versus glargine U100, it showed only in the extension period there is a numerical lowering of the events of hypoglycemia, of the confirmed hypoglycemia, 60%, but did not reach statistical significance. But was significant is the nocturnal confirmed hypoglycemia. So patients on insulin therapy, degludec insulin therapy compared to glargine U100 in the core study and also in the extension study, both have showed significant reduction in the events of hypoglycemia, about 36% and then 43%, and both were statistically significant. Also, the insulin degludec looked at cardiovascular safety in the DVOLT trial, and it showed that it's cardiovascular safe. This is the 3-point MACE. All these lines cross the hazard ratio of 1, showing not significant. Even if they extended up to 4-point MACE, as in stable angina, there was no difference. So it's cardiovascular safe. Another interesting item in insulin therapy that also can be used as a first injectable therapy in type 2 diabetics is a co-formulation of degludec, a basal insulin, with the rapid-acting insulin as an S-part. So this would be the first time we actually mix together a basal insulin, which lasts for more than 24 hours, instead of doing intermediate insulin, just like the previous pre-mixed insulins. So this is a co-formulation because they are now really mixed together. Each form of insulin, degludec and S-part, they're in the needle or the solution in its own standing setting. Degludec is formed as a dihexamers, and the S-part is formed as a hexamers. And when they are both injecting in the underlying skin, the degludec forms this long chain of dihexamers and starts slowing slow release, so it can actually give the effect within 24 hours. And the S-part does its effect in rapid dissociation and giving the effect to control post-meal levels. IDIG S-part, which is the co-formulation of degludec and S-part, has been tested against glargine U100 in patients who are insulin naive, type 2 diabetic, not controlled. What showed in these patients, so these patients either given one dose of IDIG S-part as a core formulation or the glargine U100. So there was a slight difference in terms of A1C reduction in favor of the IDIG S-part, only about almost 0.3%. It was statistically significant reduction, but the amount was very minimal. But what was interesting to see is that with insulin co-formulation, degludec plus the S-part, it helped more patients to be under control with A1C of less than 7% compared to glargine U100. So about almost 60% compared to 40% with glargine U100. And also in patients with less than 7% without hypoglycemias, also it was more significant with IDIG S-part as a co-formulation compared to basal insulin alone with odds ratio of 2.2. So the minimal differences in A1C, but large difference in patients getting them under control and getting them under control with no hypoglycemia. Also, this is the confirmed hypoglycemia generally. It was not significant in the confirmed hypoglycemias compared in both the groups, and there was also no difference in the confirmed nocturnal hypoglycemia in those two, even though the graphs kind of separate but did not reach statistical significance. Also, comparing this co-formulation versus glargine in terms of weight gain, they were both the same in terms of weight gain. There was no difference between them, even though the co-formulation also included a brandial insulin, but it did not change the weight. And the mean daily insulin doses was also similar between those two agents or the molecule at the end of the trial. So you get more patients under control. You don't raise the hypoglycemia even more when you do this co-formulation. You don't cause more weight gain, and you don't cause much more insulin therapy. Insulin doses. In terms of using GLP-1 for patients who are not controlled as a type 2 diabetics, these are the known GLP-1 receptor agonists. dulaglutide, albiglutide, exenatide, liraglutide, and lixisenatide. So these are the ones, and plus other ones. So they have their ability to reduce A1C, and they have these variation differences as you see between them, and that's basically based on the doses that are being used. The higher the doses that's being used, like 1.5 of dulaglutide, can reduce A1C about 1.2. Exenatide, the once weekly, the 2 milligram, 1.5%. Liraglutide, the full dose, 1.8, 1.5% reduction. There is a difference between GLP-1 and basal insulin. So if you compare those two agents, either give the patient a GLP-1 or give the patient a basal insulin, what you see is that in terms of A1C reduction, they will have the same reduction of HbA1c. So diabetes control will be the same between those two agents. But what's the important thing to mention is that with GLP-1, you can actually have much lower weight loss or improved weight loss. So this is a meta-analysis of all the trials that tested or did a look in terms of GLP-1 versus basal insulin. And with this meta-analysis, there was a significant favoring of GLP-1 in terms of weight loss. But in terms of diabetes control and A1C, as we mentioned, there was no much difference in terms of differences. There is a very slight, if you just compare certain types of GLP-1, there is a slight difference in favoring the GLP-1. But these agents or these studies have very mixed results, and there's a lot of other studies have shown no differences in terms of A1C reduction. So you can have basal insulin, GLP-1 doing the same degree of controlling diabetes, but with GLP-1 you get less you get more weight loss, and definitely you will get less hypoglycemia with GLP-1. This is also comparative studies between the known the GLP-1s against each other. So which GLP-1 then you want to use. These are the studies looking at liraglutide as the one main component compared to other GLP-1. So liraglutide compared to exenatide, the 2 milligram, the duration 6 trial, and also a Harmony trial and the Award trial compared to liraglutide, and compared to lixisenatide. So these agents, some of them showed differences in terms of effect favoring one GLP-1 against another. For example, with lixisenatide, and this is probably a classical difference because liraglutide is considered a long-acting GLP-1 while lixisenatide is considered as a short-acting GLP-1. So maybe this is something that you can see the differences when you're using or choosing the GLP-1. In terms of the comparing to dulaglutide or albiglutide, there was no inferiority between them. They had a similar A1C reduction in terms of how you will choose the therapy. With the duration 6, comparing liraglutide 1.8 to exenatide 2 milligram, there is more reduction of A1C with liraglutide. A little bit difference, only about 0.2%, but it was statistical significance. In terms of body weight, this is also showing the liraglutide is probably a leading in terms of improving weight loss with the use compared to the other GLP-1s. Also important to mention is the semaglutide, which is a newer agent we're starting to use here in the Gulf, and showing its a clear effect in improving diabetes control as when used in patients who are not on injectable therapy, on oral therapy only with type 2 diabetes. This is a semaglutide compared to dulaglutide. So if you look at the full dose of semaglutide 1 milligram, compared to dulaglutide of 1.5 milligram, you will see an odds ratio of 3, meaning the significant reduction of body weight or having patients, proportion of patients more than 5% weight loss. It was significantly higher with semaglutide 1 milligram compared to dulaglutide. And getting patients into more than 10% weight loss, it was also more seen in patients with semaglutide 1 milligram compared to dulaglutide with odds ratio of 4.5. Also was statistically significant even on the smaller dose of semaglutide, which was the 0.5 milligram. Adverse events with the semaglutide and the dulaglutide were kind of compatible between them. With the higher doses, you can see more GI side effects, but they're very almost similar between them. So this is all general GI side effects. They're all kind of similar between them. As you increase the dose, definitely you can increase the risk of these side effects. This is in terms of reduction of HbA1c. This is sustained trials also looking at semaglutide in terms of controlling HbA1c. In the SUSTAIN 4, they compared semaglutide, the 0.5 milligram dose, and the 1 milligram dose compared to basal insulin as glargine. And with A1C reduction, these are patients who are also insulin naive, injection naive, only on oral therapies. You can see the big difference in A1C reduction as the first injectable therapy, which is 1.6 with 1 milligram, 1.2% with 0.5, and only 0.8% with glargine. This is definitely with weight loss. You would appreciate that GLP-1 can cause significant weight loss, and this can be seen here compared to basal insulin, which has a weight gain. Also, combination therapy between basal insulin and GLP-1 would be very interesting because you can have mixed effects complementing each other. Basal insulin can reduce your HbA1c by working on fasting plasma glucose, but it has its own issue with weight gain and hypoglycemia. Whereas GLP-1 receptor agonists can have also reduction of A1C with reducing fasting and postprandial glucose, but also you get the benefit of weight loss, but you can have the issue with GI side effects. If you combine both together, you can have a powerful tool in reducing HbA1c with fasting and postprandial, and you have also less hypoglycemia compared to basal insulin, maybe even a better GI tolerability, and you can have also some net effect on reducing weight. I'm going to show you two studies which looked at this combination between basal insulin and GLP-1. This is Iglar-Lixi, Blexinitide, and glargine as a combination. These are patients type 2 diabetic, not on injectable therapy. These patients were randomized to 3 groups, either receiving the combination of the two together, glargine and Blexinitide, as one injection, or giving them only Blexinitide as a GLP-1, or give them only glargine as a basal insulin. These patients show that with combination therapy, they can actually have much lower A1C reduction compared to either arm alone. It could have even better postprandial glucose reduction compared to either separate therapy alone. And you can have more patients at target, up to 74% in patient less than 7% target compared to the other agents. And also with weight changes, you will find it almost weight neutral. And for hypoglycemia, you get the same level of hypoglycemia as basal insulin, but you don't have the weight gain that comes with basal insulin. And you get less GI side effects if you use it as a combination, compared if you just do GLP-1 alone. The reason why is that when you do a combination, you don't give the full doses of the GLP-1, you give less doses, and that's helpful in reducing GI side effects. The other study is the Ideglera. It's a combination of liraglutide and degludec together as a combination therapy. Similar scenario, patients type 2 diabetic, not on injections, uncontrolled. They randomize them to 3 groups, either receiving the combination together, which is degludec and liraglutide together as one injection, or degludec insulin as basal insulin, or liraglutide as a GLP-1. After 26 weeks, there was an extension phase of another 26 weeks. What they saw in this trial is that similarly, larger drop in HbA1c 1.8% compared to the other single agents, weight neutrality compared definitely with GLP-1 that reduces the weight and basal insulin that raises the weight, and less even hypoglycemia than basal insulin. And the amount of A1C reduction, as you see, is the largest in terms of the combination. Those two studies with combination therapies, they showed us is that A1C reduction is a powerful tool in those two combination therapies. They can do that significantly, 1.6 to 1.8 A1C reduction. Insulin dose is significantly lower with degludec and the liraglutide together, but it was similar insulin dose when using Iglar-Lixi. In terms of weight loss, both of them showed significant weight loss, even though it was minimal. And in terms of hypoglycemia, there was less hypoglycemia with degludec versus, Ideglera compared to degludec, but similar hypoglycemia when comparing the Iglar-Lixi versus glargine 100. So what the guidelines tells us about injectable therapy? It tells us, this is from the ADA-ASD guidelines, is that if patients on oral therapy are not controlled yet, then the first choice of therapy would be GLP-1 because of what the data showed comparing basal insulin to GLP-1. You can consider starting insulin if your patient is very uncontrolled, A1C more than 11%, has osmotic symptoms, or more likely is a type 1 diabetes. If the patient is not controlled on a GLP-1, then you can add a basal insulin together, or even switch the patient on a fixed ratio combination between the GLP-1 and basal insulin together as a single injection. And if the HbA1c is not controlled yet with these two agents together, then you actually start adding, the brandial doses to control their diabetes. So in conclusion, failure of oral hypoglycemic agents is common in type 2 diabetes, and progression to injectable therapies is required with further decline in beta cell function. The choice between insulin, GLP-1 receptor agonist, or combination of both for management of type 2 diabetes depends on patients' related factors, availability, cost, and experience. Insulin-depleted type 2 diabetes patients would benefit from insulin-based therapy, and GLP-1 receptor agonist is reasonable in type 2 diabetes with high cardiovascular risk and BMI, and consider intensive insulin therapy or fixed dose combination between basal insulin and GLP-1 receptor agonist in type 2 diabetic patients who have HbA1c more than 2% out of the target, so you can get a better control. So with that, I end my presentation. Thank you so much.
Thank you, Dr. Tamer, for this great and scientific presentations. There will be question and answer sessions at the end of this session. Now it's my pleasure to introduce our next speaker, Dr. Nasser Al-Johani, consultant internist, endocrinologist, and president-elect for the Gulf Association of Endocrinology and Diabetes, head of medical department, East Jeddah Hospital at Saudi Arabia. Dr. Nasser will talk about a new generation insulins. Dr. Nasser.
Assalamu alaikum. First of all, I want to thank Mr. Chairman for this nice introduction. And I want to thank the organizing and scientific committee for kind invitation. My presentation today will be about the new generation insulin. I disclose none for this presentation, and this is my agenda. We'll talk briefly about the recent insulin analog, then ultra-fast acting insulin, then ultra-long weekly basal insulin. I will talk actually briefly about the inhaled insulin and oral insulin. As we know, insulin is life-saving in type 1 diabetes, and it is the most effective glucose-lowering agent. Adding second oral agent or GLP-1 receptor agonist to initial immunotherapy in type 2 diabetes generally lower hemoglobin A1c by 1 to 1.5%. So actually most patients with a prolonged duration of diabetes, they eventually will need insulin for glycemic control. This is the different types of the approved insulin in different countries, like basal insulin, like Glargine 100, 300, insulin Ditimer, insulin Degludec, or brandial insulin like regular insulin, inhaled insulin like Afrezza, insulin Lispro, ultra rapid Lispro, insulin Globazin, insulin Aspart, or fast-acting insulin Aspart, or pre-mixed insulin biphasic insulin 3070, biphasic insulin Aspart 3070, biphasic insulin Lispro 25/75 or 50/50, or insulin Degludec Aspart 3070. There is limitation of the current basal insulin. Actually, current basal insulin is not truly peakless. So there is variability in the absorption. So this is may predispose to hypoglycemia. The other thing regarding the current basal insulin, Glargine and Ditimer, the duration is not actually, sometimes in some patient does not extend to 24 hours. So there is lack of flexibility in dosing regimen. The other thing, there is risk of hypoglycemia with the current basal insulin because they don't have completely flat profile. So the challenge with the current new generation basal insulin that they reduce nocturnal hypoglycemia, and actually also there is a flexibility in the dosing. So the first of this long-acting insulin analog is insulin Glargine 300. It is approved by FDA 2015. Duration of action extend to more than 30 hours. And if you compare it to Glargine 100, there is similar reduction of hemoglobin A1c, but decrease the variability and also there is a reduction of the nocturnal hypoglycemia by 20 to 30%, depending on the study and the type of the patient, whether it is type 1 or type 2 diabetic patient. Also, there is a slight weight gain, 0.2 to 0.7, slight least weight gain from 0.2 to 0.7 compared to Glargine 100, and also there is flexibility in the dosing of 6-hour window. The other important long-acting approved basal insulin is Degludec, either 200 units or 100 units per ml. There is no difference in pharmacokinetic. It also approved by FDA in 2015, and the duration of action is more than Glargine 300, extend up to 42 hours. If you compare it to Detamar or Glargine, there is similar reduction from hemoglobin A1c, but decrease variability within the individual, day or subject variability, also decrease the risk of hypoglycemia, especially nocturnal hypoglycemia, and also there is flexibility of the dosing. For example, in Wednesday and Thursday, they give it in the morning. In the Friday, they give it in the evening. Because of the length duration, it allows for flexibility of the dosing. If you look for the study that compared Glargine 300 versus Degludec, there is more similarity than difference between both insulin. So, for example, in a prior study, the hypoglycemia risk is almost the same. Although insulin Glargine 300 showed better reduction of hemoglobin A1c in advanced renal impairment or in elderly patient above the 70, but really the risk of hypoglycemia is the same. Also, if you look for head-to-head comparison, in conclude study that compared Glargine 300 to Degludec, although they mentioned in this study that there is hypoglycemia less with Degludec, but unfortunately there was an accuracy of the glucometers that detect hypoglycemia. So, in conclusion, there is inconclusive evidence in reduction of hypoglycemia if you compare Degludec to Glargine 300. The ideal patient for low volume insulin, basal insulin, or concentrated insulin like Glargine 300 or Degludec, patient with recurrent nocturnal hypoglycemia, those patients who require flexibility in the dosing, or those patients who require high basal insulin dose. So in this patient, you can shift to Glargine U300 or Degludec U100 or U200. The other fixed combination of the new insulin analog approved in new insulin analog is insulin Degludec plus insulin aspart 70/30, given once daily or twice daily. If you compare it, the study compared it with insulin aspart 70/30, they found similar reduction of hemoglobin A1c. There is no difference between it and Nofoloc or Nofonex, but there is a reduction of the hypoglycemia, especially nocturnal hypoglycemia, but there is no difference in the rate of severe hypoglycemia. The other important combination of GLP-1 receptor agonists with basal insulin, almost all the GLP-1 receptor agonist is approved for combination of basal insulin, especially basal insulin, and there is fixed combination approved in 2016, insulin Degludec plus liraglutide, showed reduction of hemoglobin A1c up to 2%, and there is reduction of the weight almost to 3 kg, and there is lower risk of with hypoglycemia if you compare it with Degludec alone. Also, the other combination or fixed combination is insulin Glargine lexilitide. So this combination is promising, may improve adherence, and may reduce the side effect like the weight gain or the hypoglycemia of compared to insulin alone. The other important insulin is ultra-fast acting insulin, faster acting aspart, or ultra-rapid insulin lispro. We know there is unmet needs with the current with the current meal insulin analog. Limiting postprandial glucose excursion is important aspect of overall glycemic control. Postprandial hyperglycemia is associated with diabetic complication, especially cardiovascular disease. And the current rapid-acting insulin analog, actually, they have delayed onset of action and longer duration. So actually, they are not physiological like the normal insulin secretion. If you look here in the black here, this is the physiological insulin secretion. If you look here, the regular insulin should be given usually 30 minutes before the meal, and even the peak is not acute. There is no rapid absorption. So the peak of the regular insulin does not coincide with the normal insulin or like insulin secretion. With the insulin analog also, if you look for insulin analog, this is in brown. Also the start rate and also the peak is not match the postprandial blood glucose excursion. So what's the solution? What's the ideal bolus insulin meal? Or meal insulin? The ideal meal insulin is there is rapid absorption, rapid onset of action, and shorter duration. Once the meal finished, okay, this is will limit the postprandial hypoglycemia and it improves postprandial blood glucose and lower risk of hypoglycemia. If you look here for the ultra-fast lispro here and compare it here with insulin lispro before the meal type 1 diabetes, you can see ultra-fast insulin lispro, the action, there is rapid absorption and started before the meal. And also the peak is acute. There is higher peak. So this peak match the postprandial blood glucose rise after the meal, not like the actual lispro insulin. And the duration of the lispro insulin is higher compared to the ultra-fast lispro. So the first of these faster-acting insulin analog is Fiasp, or FDA approved in April 2017. In 2020 is approved in children more than 2 years. The first study in diabetes care in 2017, the fasting-acting insulin aspart improved glycemic control in type 2 diabetes, or Onset 1 study. In this study, they compared the insulin aspart mealtime. This is okay in brown, okay, with the faster aspart mealtime in the blue. If you can see here, the faster insulin aspart mealtime decreases blood glucose at 1 and 2 hours more compared with insulin aspart. Here they compare the fast insulin aspart if given post-meal or given with meal. So if you give faster insulin aspart with meal, it's better than post-meal because it reduces postprandial hyperglycemia. Here this is the meta-analysis. There is a slight reduction of nocturnal hypoglycemia in Onset 1, Onset 8, and BOLD study of Onset 1 and 8, almost 16% with ultra-rapid insulin aspart compared with insulin lispro. So it is FDA approved, can be given 2 minutes before the meal or 20 minutes after the meal, error onset of action 2.5 minutes, improve postprandial hypoglycemia. The reduction of hemoglobin is the same like insulin aspart, may lower postprandial hypoglycemia 4 hours after the meal. The other ultra-rapid insulin lispro or Zolomigef is approved in 2020. Okay, this study, based on this study, ultra-rapid insulin lispro improved postprandial glucose control compared with the lispro in type 1 diabetes, or Boronto type 1 study. Here they look for ultra-rapid lispro insulin. They give it mealtime and they give it post-meal. They compare it with lispro insulin at mealtime. If you can see here in the bold line, the red line, that the ultra-rapid lispro insulin, if given with mealtime, this will reduce hemoglobin A1C more if compared with the lispro, or if you give ultra-rapid lispro post-meal in type 1 diabetic patient. Also here, if you give ultra-rapid lispro at the meal time, 2 minutes or 0 time before the meal time, it will be superior to lispro, so reduce the postprandial blood glucose at 1 hour and 2 hours. Also here, if you look for the hypoglycemia between mealtime ultra-rapid lispro and mealtime lispro, in the first 4 hours post-meal, there is similar hypoglycemia incidence. But more than 4 hours, there is a trend for mild reduction of hypoglycemia with ultra-rapid lispro insulin given at mealtime. So in conclusion, in Bronto type 1 diabetes, mealtime ultra-lispro demonstrated non-inferior hemoglobin A1C reduction compared to lispro, superior postprandial blood glucose, both at 1 hour and 2 hours. Regarding the post-meal ultra-lispro, demonstrated non-inferiority, there is less reduction of hemoglobin A1C. The safety almost the same. There is almost a trend for lower hypoglycemia with ultra-rapid lispro. The other thing, there is more side reactions with ultra-rapid lispro, but it usually is mild compared with lispro. This is a concentrated insulin or Humulin R. It is very concentrated. The main indication, we use it in the severely insulin-resistant patient. If the total insulin dose more than 200 units per day, it is available in BIM now and approved in 2016. The other innovation in insulin therapy is ultra-long weekly basal insulin, icodic. This is still investigation. Weekly basal insulin is important advancement in insulin therapy. It will improve compliance and adherence. The other thing, if has flat insulin profile, could reduce within day glucose variability, and this could result in more consistent and predictable glycemic control. This study of once weekly insulin, icodic, okay, acylated insulin attached to albumin in type 2 diabetic patients, okay, published in the New England Journal of Medicine 2020. It is double-blind phase 2 trial. They compare the safety and efficacy of once weekly with basal insulin analog icodic given once weekly, 70 units, or with basal insulin glargine 100 given as 10 units daily, and the dose adjusted in the weekly insulin by adding 28 units if blood glucose more than 110 milligram in the week, and also the insulin glargine 100 adjusted weekly once if the blood glucose more than 100 or if the fasting blood glucose more than 130 milligram per deciliter. So this is the group, icodic group 125 patients, glargine group 122 patients. The hemoglobin A1C is almost 8 comparable. Both insulin, once weekly basal insulin and insulin glargine 100, they reduce hemoglobin A1C similarly, although in icodic there is slight reduction of hemoglobin A1C more compared with daily insulin. The main advantage of this, we can give icodic, for example, weekly, so 52 times per year, but we give glargine 365 times per year. The other thing, they achieve almost similar patients that they achieve the target. So if you take the target, at least almost 70% of the patients, they achieve the glycemic target. Also, there is less insulin dose in insulin icodic or weekly insulin compared with the glargine. Here 30 units per day. Here in glargine 41 units per day. The other thing, there is slight increase of the hypoglycemia with the insulin icodic. The main reason because they go to treatment and target, they go to lower glycemic control from 70 to 110 milligram, and they advance the weekly dose of icodic by 28. So probably if we keep the target 80 to 130 milligram per deciliter, the target of fasting blood glucose, we keep it 80 to 130 milligram per deciliter, or if we increase the dose of weekly insulin by 21, probably the hypoglycemia risk is the same. This is another study. They switch from once weekly insulin, they switch to once weekly icodic insulin versus continuation of the daily insulin glargine, okay, phase 2 trial. So in this study, when they switched to once weekly basal insulin, they found similar glycemic control, and actually there is no increased risk of hypoglycemia. This is another molecule of weekly insulin, insulin FC fusion, studied here in type 2 diabetic patient using continuous glucose monitoring. This is the patient 132 in 3 arms. The first basal insulin is they keep target blood glucose 140. In the second arm, they keep target blood glucose 120, and patient in Dubledic, they compare it with Dubledic, they keep target 100 milligram per deciliter. So really, almost there is comparable reduction of hemoglobin A1C, and it is not inferior to Dubledic. So once weekly BIV insulin is comparable to Dubledic regarding the reduction of hemoglobin A1C. Also, the same patient in green, they reach the glycemic target. Also, the percentage of the time in the range is almost comparable, almost 60% in both the 3 arms. The other thing, there is a trend toward lower hypoglycemia with insulin, with basal, long-acting basal insulin. So the co-formulation of once weekly basal insulin icodic plus once weekly GLP receptor agonist semaglutide in the same pill will be exciting if this is available, and this study is now in phase 1 trial. So regarding the oral insulin, it is investigational. In this study, they compare long oral insulin with glargine 100 in type 2 diabetic patient. They have 50 insulin naive patient with hemoglobin A1C 7 to 10%. They give oral insulin. They compare it with glargine, and they look at 8 weeks for fasting blood glucose. If you can see here, this is at 8 weeks. The reduction of the fasting blood glucose is comparable with long-acting basal oral insulin and basal insulin glargine, so almost similar. But really, unfortunately, the company discontinued the production of this molecule because we know that what the main problem with basal insulin or oral basal insulin is the bioavailability. So you require 58-fold higher dose, okay, of oral insulin compared to glargine sub-Q. So this is probably not cost effective, and the production will require large amount of insulin. There is also development of oral insulin transport because there is an novel oral insulin capsule that can deploy microneedles that release a drug into the intestinal wall for uptake into the bloodstream as shown in animal studies. So let's look for this box. This is attached to the wall of the small intestine and release the insulin in the intestine. Still oral insulin under investigations because the problem is bioavailability, the problem in the absorption, the problem in the effect of the food, the problem is the effect of the gastric empties. So we need more improvement of the transfer for the oral insulin. The other type of insulin is inhaled insulin, DANS 500-01 inhaled insulin. This is study they look for type 2 diabetic patient. They compare DANS inhaled insulin powder with sub-Q insulin Lispro. It is inhaled powder. Okay, this is the inhaler, and this is how to inhale, and this is a liquid form. This look for glucose infusion rate. This is, for example, they have 21 patient, type 2 diabetic patient. Okay, this patient, they give him 6 doses of the DANS inhaled insulin, low dose, higher dose, and high dose. And they compare it with Lispro 12 units, Lispro 24 units, and Lispro 48 units. The bioavailability of the inhaled insulin, 12%, okay, of the dose of the sub-Q insulin. So you need higher dose actually. If you compare here, in the black, this is the DANS, has earlier onset of action, if you can look here. And also in 1 hour, there is more reduction of blood glucose. So the peak is not. So they are almost similar. This is in the red, is the Lispro insulin, the 12 dose. This is the 24 days of the intermediate dose, and this is the higher dose, 48 dose. So almost comparable, although there's earlier onset of action. So in conclusion, DANS 501 inhaled insulin showed faster onset of action with otherwise comparable dynamic properties, demonstrated good tolerability, no cough after insulin inhalation. It is still under development. It will be alternative to rapid acting insulin injection, especially with the presence now of the continuous glucose monitoring device. And there is also batch, bolus insulin batch or basal insulin batch. This will release the insulin slowly from the skin, still under investigation. And the animal studies showed that reduce the blood glucose. And last slide, this is the intranasal glucagon powder. This is as alternative to intramuscular or deep sub-Q glucagon. It will be more convenient. It is used in case of treatment of severe hypoglycemia, but the major issue with it is the expense. Thank you for you.
Thank you, Dr. Nasser.
I would like first to thank Dr. Nasser for his excellent lecture, and we go to our next speaker, Professor Jay Skyler. He was introduced earlier this afternoon, but I would like to mention a few things in his biography. He's a professor of medicine, pediatric, and psychology at the University of Miami. And also he is a chair of the Strategy Advisory Group for Innodia. This is a European consortium of academic and industry groups developing innovative approaches towards understanding and arresting type 1 diabetes. He was the president of the American Diabetes Association and the vice president of the International Diabetes Federation, and he was the founding editor-in-chief of Diabetes Care Journal. Professor Skyler will talk about the immunotherapy of type 1 diabetes. Professor Skyler.
I'm going to talk about immunotherapy for type 1 diabetes. My disclosures have not changed since my earlier talk. And I'll remind you that type 1 diabetes is an immunologically mediated disease. One of the best ways we recognize that is from this classic photograph from the late Wally Gepps from Denmark, which shows a monotonous mononuclear infiltration in pancreatic islets. And these turn out to be lymphocytes and macrophages that are there, and indicating that there is an immunological attack. And the immunopathogenesis of type 1 diabetes is that antigens are presented by professional antigen presenting cells. Dendritic cells are macrophages. They're presented in the context of the major histocompatibility complex. Here's a peptide in there recognized by the T cell receptor on a naive T cell. That we call signal 1. And in order to activate that naive T cell, you also need signal 2 or co-stimulation. T cells can get some help from B cells, but once the naive T cell is activated, it becomes a T effector cell, either CD4 or CD8, which can either directly attack beta cells or secrete cytokines like interferon gamma, IL-1 beta, TNF alpha that attack the beta cells. Alternatively, naive T cells can differentiate into T regulatory cells. They're protective. They'll try to downregulate the effector T cells. And so we have the immunopathogenesis of disease in a nutshell. I'm greatly abbreviating that. But what we have here is the natural history of type 1 diabetes, as originally graphed by the late George Eisenbarth. We have at birth our beta cell function intact, and those with a genetic predisposition to the disease, or actually where the genetic predisposition outweighs genetic protection, are the ones who are prone to the disease. And an environmental trigger presumably initiates the immune attack. That may be a virus, it may be something else. But the attack is cellular T cells that are attacking and create the insulitis, the picture I showed you, and beta cell injury. And with that beta cell injury, there is the production of humoral autoantibodies measurable in the circulation. Islet cell antibodies originally measured by immunofluorescence, antibodies to insulin, to glutamic acid decarboxylase or GAD, to IA2, to zinc, and the like. We don't think they do any damage, but they do indicate that damage has been done. During that period of time, we're losing some of our beta cell function. That can be measured by the loss of first phase insulin response to an intravenous glucose challenge, or to dysglycemia on an oral glucose challenge. But dysglycemia means that it has not reached the threshold of the diagnosis of diabetes. Once it reaches that, we have the clinical onset of the disease. Now, although the slide shows this as a straight line, it really occurs in waves probably, and not all progressive all the time. And in fact, we've also gone ahead and over the last several years and reclassified what these stages are. So when you have just the genetic predisposition, we call that pre-stage 1. When you have 2 or more of the autoantibodies that I mentioned, we call that stage 1. When you have evidence of dysglycemia or abnormal beta cell function, we call that stage 2. And when you have the clinical onset of the disease with or without symptoms of meeting the glucose criteria, we call that stage 3. And so The stages 1 and 2 are collectively called pre-symptomatic type 1 diabetes, and then symptomatic or hyperglycemic type 1 diabetes is stage 3. If you were to try to intervene back here with those with just a genetic predisposition, that would be primary prevention. If you intervene in stage 1 or 2, that would be secondary prevention. And if you intervene in stage 3, that would be either tertiary prevention or immune intervention to stabilize the disease. Type 1 diabetes, stage 1, as I said, is characterized by antibodies. And the greater the number of antibodies, the greater likelihood you have the disease develop. Here are some 29,000 people that we followed in DPT-1. 100% are free of the disease when they were enrolled. And if they had 0 or 1 antibodies over 10 years, very unlikely to progress, but they progressed with the appearance of diabetes of 2, 3, and 4 antibodies, progressively greater. And in fact, if you screen babies at birth and you follow them until they develop 2 antibodies and then follow them progressively over time, what you find is time 0 is when they have 2 antibodies. The likelihood that they'll develop diabetes over the next 20 years is nearly 100%. And that was from 3 cohorts which were looked at together, one from Colorado in red, Germany in green, and Finland in blue. Type 2. Stage 2 is characterized by dysglycemia. And here one can see from people we enrolled and followed in DPT-1, they're 100% free of disease at the time of enrollment. If you had normal glucose tolerance, this is your rate of development of the disease over 6 or 7 years. But if you have either impaired glucose tolerance in blue or combined impaired and impaired glucose tolerance, here is in green. If you have combined of impaired fasting with either impaired glucose or indeterminate, you're in green. And indeterminate here is a blood glucose above 200 milligrams per deciliter or 11.1 millimoles per liter at 30, 60, or 90 minutes on a glucose tolerance test. If it was there at 120 minutes, that would be the diagnosis of diabetes. But you can see, if they have dysglycemia, they've got a 75 to 80% risk over 5 years. And their beta cell glucose sensitivity has declined as well. Here you can see people who did not progress to the disease, non-converters baseline, and then followed over time, that their beta cell glucose sensitivity was more or less intact. For those who were going to convert, they already seemed to have a decline at baseline that progressed further by the time we had the last follow-up, before the development of the disease. What about stage 3, clinical disease? Well, there, the ideal therapeutic goals today are automated insulin delivery. In the future, it may be replacement or regeneration of beta cells. But I think in order to be successful with the latter, we really need to have prevention of the immune destruction to preserve beta cell mass or function. And so we want to stop immune-mediated damage and thus preserve beta cell mass or function. These are the studies I've been involved with over the last numbers of years for that. I had the privilege of chairing both the diabetes prevention trial for type 1, which had 2 studies back here, and type 1 diabetes TrialNet, which had a host of studies over a period of many years until I stepped down in 2015. And these are the studies we initiated on my watch. I'm going to talk about intervention to prevent clinical type 1 diabetes in stage 1 or 2. This is the parenteral insulin trial that we did in the diabetes prevention trial. We enrolled for this people who had at least a 50% likelihood of developing type 1 diabetes over 5 years. And you can see at 5 years, 60% had diabetes. Our prediction was correct, but our intervention didn't work. This is the treated and the controls, unfortunately. At the same time, we enrolled people in an oral insulin trial, and these could have a 25 to 50% risk. So if you look at 5 years, here's the risk. It was 35% having the disease. Our prediction, again, was correct as to who we should enroll. But again, when one looked at the impact, oral insulin versus placebo, no statistical difference. We did have a subgroup that suggested there might be difference. So we went ahead, and since that subgroup was identified post hoc, we went ahead in TrialNet and studied them again. And here in the TrialNet oral insulin study, in the primary stratum, which was to replicate the subgroup that had a beneficial effect, we didn't see one that was statistically significant. So again, we failed to see the effect. Very frustrating. Nasal insulin done by the Finns in the DIP trial. Again, rate of development of the disease over time, identical in the two groups. Hazard ratio 1.14 to p-value 0.55. The Diaprevit trial with a GAD vaccine presented just a couple years ago in 2018. Placebo here, GAD here. No statistical difference. The p-value is 0.573. The Trigger study, large study that enrolled several thousand babies, and they were treated with either a control formula or a hydrolyzed infant formula trying to remove the cow milk protein. And what one sees is that the cumulative survival of at least two antibodies here or at least one antibody here were basically identical, and it turns out ultimately the development of diabetes was basically identical. Here's nicotinamide. I loved the name of this study. This was the END-IT study, designed to end type 1 diabetes. European Nicotinamide Diabetes Intervention Trial. Great acronym, great logo, the end of the rainbow. Here's the cumulative incidence of diabetes, nicotinamide, and placebo. They're both the same. Again, no effect. Very frustrating with all these prevention trials and no effect. Finally, though, the teplizumab prevention trial that we did in TrialNet, we see a beneficial effect. These were people who started in phase 2, that is to say they already had dysglycemia, and they were randomized to teplizumab or to placebo. And here's the rate of development of diabetes from 100% free. You go down here to the time that 50% have developed the disease. In the placebo group, it's back here, they reach 50%. The teplizumab group, they don't reach it till out here. Whoops, where is that? That is a 32.5-month difference, a delay in the appearance of the disease. Statistically significant, about 53.5%, 54%. And you can see 50% of the teplizumab group developed type 1 diabetes. 50% were free of the disease. In the placebo group, 78% developed it, 22% free, and the time to the median diagnosis was 27.1 versus 59.6 months. What that means is that teplizumab, given only for 14 days at the time of enrollment, a brief treatment, was safe and had potential long-term benefits. And beyond 5 years, 18% of the teplizumab treated group and only 6% of the placebo group did not have diabetes. This was the first drug to demonstrate preservation of beta cell function, leading to the delay of onset of, and potentially in some patients, the prevention of clinical type 1 diabetes. What about intervention in new onset clinical type 1 diabetes, stage 3? Well, many interventions have been tried to try to interrupt this sequence of events that I showed you earlier at all sorts of stages. Oral insulin or GAD vaccine at the antigen stage, anti-CD3 or thymoglobulin ATG to stop the presentation and activation of naive T cells, abatacept to stop the co-stimulation, rituximab to stop the B cell help, alefacept to stop the effector effect, a number of drugs to stop the cytokines, IL-2 to try to stimulate the regulatory T cells, all sorts of things tried. I want to show you in general what's happened. Transient beneficial effect, and then a decline. Transient effect, and then a decline. Here's an effect better than the placebo. Here's one where you actually have an increase of effect and then a decline. Let's look at that one a little bit more closely. It was a study reported by Bart K. Mullen in 2005 using the anti-CD3 monoclonal antibody ocilixuzumab, similar to the teplizumab that I mentioned earlier. You can see initially a rise in beta cell function and then a decline in parallel to the placebo group. But they measured beta cell function by using a hyperglycemic clamp followed by a glucagon stimulation. And they had asked patients to have those done up to 18 months. And statistically significant difference versus placebo. But then they brought the patients back in at the end of 4 years, and most of the patients would not have a clamp again. But if you actually looked at their insulin dose out at 4 years, here's the previously treated patients. They only had 6 days of otrelixuzumab at the time of enrollment versus placebo. You can see there's about a 30% decline of insulin dose that is maintained, even though A1Cs were identical and were really well controlled as a whole in both of the groups. So this shows you that you can have a long-term effect from a short-term treatment, depending on the treatment. The ABATE study with teplizumab in new onset diabetes looked like it preserved beta cell function initially and then declined in parallel to the control group. But if they separated out drug responders from non-drug responders, the non-drug responders looked like the control group, and the drug responders looked dramatically up here like they were preserving beta cell function pretty much intact for 2 years. And that was about 50% of the subjects, 50-50 responders, non-responders, suggesting that not everybody may respond, and we need to look further to figure out who does. Here is another study that we did in TrialNet with low-dose thymoglobulin, ATG. We also did a group where we mixed it with G-CSF. But you can see here the ATG group alone in blue compared to the placebo group in red, statistically significant 0.0003. And the ATG with G-CSF, you had to be less than 0.025 because we divided the p-value in half to be significant. This was not significant, and it did really not work as well as the ATG alone. This is the 1 year data. Here's the 2 year data, continuing to show beneficial effect, but there is a decline in here. And this was only 2 days of treatment back here at enrollment, but prolonged effect out here at 2 years versus placebo. So some drugs, depending on where they work, may have a prolonged effect. Here's an example of another study. This is anti-TNF with golimumab, the TIGER study. You can see it out at a year, it looked like it was preserving beta cell function. But you stopped the drug at a year, and that went down in parallel to the placebo group, off therapy. Important lesson, you can use anti-TNFs in people with rheumatoid arthritis for a protracted period of time. Why stop? That's a question one could pose. Here's another one where that same question comes up. This is a combination study of anti-IL-21 plus liraglutide. This to preserve beta cell function, this to stop the immune attack. Here in red is the combination group. Looks like out to 54 weeks on drug, both drugs, it seems to be working and preserving beta cell function. Here is placebo down here. Here is liraglutide alone. Here is anti-IL-21 alone. They were not having the effects. But if you stop the drugs and go out to another half year, you can see the effect dissipates. Don't stop it when it's working. Certainly not something that's improving beta cell function like liraglutide. Here's imitinib. This is a drug used for leukemia. It's a tyrosine kinase inhibitor. It was used for 6 months here, and this was statistically significant between the drug and placebo, but then it declines rapidly in parallel to the placebo drug during the next 18 months. Here they measured the change of beta cell function, looking at glucose sensitivity, and that looked like it improved while they were on drug and then declined when they went off drug. Again, suggesting you need to continue the drugs many times if you're going to see the effects. Well, the other thing I think that we get from that combination of anti-IL-21 and liraglutide is that we may need to be using combination strategies. I propose an aggressive combination strategy. There's 3 components of the immune system. There's the innate immunity or inflammation. There's adaptive immunity. and there's regulatory immunity, the beneficial immunity. And I think we need to be looking at all three of those, as well as trying to improve beta cell health. So I would propose we need to be using a 4-drug therapy, and we've called that diabetes islet preservation immune treatment, or DIPIT trial, which we're hoping to be able to do. We've got an IND from the government to do it. It would use an anti-inflammatory agent such as anti-TNF continuously. It would use short-term ATG or anti-CD3, which only need to be used short-term to stop the immune attack. We would try the adaptive immune response. We would try to drive the regulatory T cells with IL-2 low dose and try to preserve beta cell health with a GLP-1 receptor agonist. Hopefully, we will be able to do that trial and hopefully achieve success, because our goal is to prevent immune destruction, to preserve beta cell mass or function. I think that's going to be an essential component, not only by itself, but in context of trying to preserve and replace and regenerate beta cells. So I'll stop there, and thank you for your attention. These are the people who supported my research in this field over the years. Thank you.
Thank you, Professor Skyler, for this great presentation. Now it's my pleasure to introduce our last speaker for this session, Dr. Aus Al-Zaid. He is diabetes consultant at Riyadh, Saudi Arabia, also visiting professor molecular biology at Karolinska Institute in Stockholm, Sweden, and Barbara Davis Center for Childhood Diabetes in Colorado, USA. Dr. Aus will talk about critique for the current diabetes guideline. Dr. Aus?
I'm delighted, honored, and thrilled to be a speaker at this conference, and I would like to take this opportunity to wish the Gulf Association for Diabetes and Endocrinology the very best for the future. Now, I'm grateful for the organizing committee, obviously for the personal invitation, and also for the choice of topic, diabetes guideline, a very important topic. A confession is that I'm not an expert in the field of guidelines. I'm trying to share with you my reading of the literature and kind of blended with my own clinical experience. I have no financial or intellectual conflict of interest. Now, guidelines, and by guidelines, I mean all includes consensus statement, expert opinions, and so on. These are a key part of everyday clinical practice. And we tend to think we follow guidelines, and it's indicative of the academic well-being of the individual doctors. You follow the guideline, you know what's going on. Very important, so that you know what to offer your patients. So this presentation will attempt to offer tips and concerns regarding interpretation, strengths and limitations of guidelines available, with the idea that hopefully it'll help you make the right choice. First statement, this is not guidelines. This is drug algorithm scheme. I say this because many physicians, unfortunately, think guidelines are drug algorithm scheme. It's not. This is only page 6 of the 34-page ADA guidelines. This is only one step in a long multi-step recipe. At a recent meeting, I asked the audience to raise their hands if they're following the ADA guidelines, and almost everybody raised their hand. But then I asked who actually read the 34-page document. I think only few people had their hands up. So guidelines is not drug algorithm. It's much more than that. Because I believe after 30 years of experience, clinical experience in diabetes and caring for people with diabetes, I believe diabetes treatment depends more on better care than superior drugs. All drugs start as novel therapies when first marketed. The novelty wears off with time, or when the patency expires and the marketing storm subsides. The realities on the ground is that diabetes control has changed very little over the years. So to me, if there's a message, a clinical practice message, is that practice confined to drugs is like attention to the car you want to buy without proper knowledge of the rules of the road. It takes two to tango, human care and medications, to achieve effective, successful diabetes care. I say this because I see the attention paid to drugs. If you have hypothyroid, all you worry about is the thyroxine. But diabetes, there's much more to diabetes, almost a way of life. And what do I mean by the human side? Of course, it's the patient-centered approach. It's the empathic care, summarizing here, factors that impact the choice of treatment, shared decision-making, etc. The best section I've read on the subject is written in the ADA statement, guideline, consensus statement. That is, and everybody should be familiar with that. Don't just look at the page 6. Why? Patient-centered approach is important because it makes a difference to clinical outcome. Scientifically speaking, it makes a difference to clinical outcome. It's prioritized in all guidelines. It's a professional obligation on everybody. And patient-centered approach, it's not about being nice to your patient or, small chat or spending longer time with the patient. It's much more than that. It's about being interactive, effective interaction and engagement of the patient. Like I said, diabetes is not just about drugs. It's much more than that. The mechanism for that is effective communication. And in my opinion, that is missing, the missing link in many clinics. And if I were to advise, I think we need to push with clinical emphasis to enhance doctors' performance. We know drugs performance, we can estimate that, but we don't know how doctors, and that's a critical part. What goes in here is vital to the performance of the patient, the outcome. It's the small gestures, it's the language, it's the listening, it's the interaction. And so I would encourage researchers, people enthusiastic about diabetes, to look into this more in the future. We know that artificial intelligence, for example, now we have programs that can read the mindset of the patient, the emotional response. It's like customer satisfaction. And that would be a nice thing to study and look into. Don't have all your eggs in one basket, drugs. The first thing I want to say, or the first thing I do when I look at a diabetes document, I don't look at the first page. I look at the last page first, which is the acknowledgement. Because unfortunately, guidelines often are packaged and delivered by pharma companies. And this is the type of statement you see in acknowledgement. This work was funded with unrestricted grant from X Pharma, or authors would like to thank pharma company, X pharma company, or Y pharma company for funding the expert panel meeting and the medical writing. So it's almost like Amazon delivery. So pharma is a business industry. It's not a charity organization. They have products to sell and promote. They're entitled to look after their interests, as long as they play within the legal and ethical boundaries. But guidelines are a huge professional responsibility. It's not like, writing an article or a small study or something like that. This is millions of people follow. So independence must be maintained. So the first message is be aware of the invisible authors. Diabetes guidelines are meant to help, not overtake or substitute your role as a physician. And I like the ADA of 2015, which, the first line is metformin they give you, and then they give you a window of opportunity for you to exercise your right, your privilege as physician, your professional mission. Because the doctor should know an efficacy, the risk of hypoglycemia, weight, side effect, and the costs of drugs involved. No one should tell you that if your patient is rich or VIP, you should offer them expensive drugs. If they happen to be poor, just give them sulfonylurea or cheaper drugs. I am not aware of any other guidelines that say, a drug for the haves and another for the have-nots. So please avoid reflex drug prescription. Apply common sense and draw from your own clinical experience. Another point to make is that consider the bigger picture. I have noticed lately that we've become a p-value culture. An article in the New England Journal of Medicine, p-value under 0.05, and everybody running for their prescription pad. That's not right. P-values tells a statistical difference, not the reproducibility. Obviously, you need your confidence interval and so on. And then not clinically, they don't give you clinically meaningful. The difference is not always relevant. Significant p-values does not mean everybody gets benefit. Because I get the impression that some doctors, whenever they see a p-value positive, significant, that they think everybody they're going to see in the clinic is going to get benefit from the drug. For that, you need to do the number needed to treat, to prevent an event. And I think people should be familiar with that. Just to give you an example, if you take the DECLARE study population, and this is just a random, just to give you an idea, the number needed to treat is 1 in 107. So in other words, one patient will benefit out of 107 people treated for 4 years. One patient gets benefit. But what do you tell the other 106 patients? Take this drug for 4 years and expect no benefit? You have to get that mindset. For comparison's sake, number needed to treat for statins, and they're cheap and very simple, is 1 in 30. Cost is important. Here's a cost. I made kind of a crude estimate myself, and I hope I got it right. Cost estimate in Saudi Arabia. Well, if we took the DECLARE population as an example of, treat 1,000 patients per year to prevent 2 episodes of heart failure. I think the price per month is 160 generally for SGLT inhibitors. For 12 months, 1,000 patients is almost 2 million. And that does not include the cost of DKAs, genital infections, and amputations. And these are not serious because even they may be rare, it's a catastrophe for the patient to lose a limb. And there's also an ethical obligation that not everybody seems to be aware of. Here's what the American Board of Internal Medicine Charter says. Physicians are required to provide healthcare based on wise and cost-effective management of limited clinical resources. We can look at the local data, local costs. This is a table, shows you the class, and doesn't include insulins, but the 6 classes of oral diabetes medications, annual cost in Saudi Riyal, and we made metformin as a reference. And you can see a year of metformin and sulfonylurea is about 100 to 300. A year of something else is almost 10,000. In other words, what you give a patient for a whole year, a supply of a whole year, is equivalent to a week of another drug. And remember, not everybody benefits. At that price, you need to be able to live forever, in my opinion. And this is in reference to the cost. Cost must be viewed as like access to medication. Cost must be viewed as a side effect. It bothers patients. So avoid open buffet approach. And to be honest, I don't like the ADA kind of the way the things have been formulated. If cost is an issue, use cheaper drugs. The word cheap has almost derogatory. It indicates kind of a subtle, low-quality drug. And there's nothing wrong with the standard drugs, medications that we've used for years. I would have said, if cost is an issue, avoid expensive drugs. The ADA has put expensive drug as a default And cost is an issue. Type 2 diabetes is not a rare disease. It's a national burden. It's a Gulf crisis. The other point I want to make is that there's plenty of choice. You need to be familiar with a variety of guidelines that are available. The ADA is the most visible, strong emphasis on SGLT and GLP-1 analogs. But there's life beyond the ADA. And we shouldn't treat guidelines as a form of religion that you're committed 100%. You can't deviate for any reason. There are other guidelines, just as a sample here. And I'm familiar with the statement from the SSEM, Saudi Society of Endocrinology and Metabolism, published recently, with special emphasis as well on adherence cost. So adherence is not just mentioned in the details; it's actually used as a dividing factor. Cost, culture, we have to relate things to our environment. The point here is that, while the emphasis is on SGLT, and unless I must make an admission, I haven't been familiar with any recent changes or modifications, but in general, they recommend metformin followed by standard traditional agents. In other words, like we saw with the ADA, what I call ADA like 2015. So the question now to everybody, if the scientific evidence is the same and it's available to everyone, why the different interpretation? Do people think that the one organization has superior scientific knowledge, superior analytical tests, or they care more about people with diabetes than others? It's not. It's about people behind the guidelines. It's about the jury looking at the evidence and the approach taken. And just as a comparison's sake, if you take the NICE guidelines, there is zero conflict of interest, broad and independent expert opinions like scientists, GPs, nurses, epidemiologists, health economists, lay people, broad-based assessment of benefit, number needed to treat, value for money, etc. Not just the p-value. Unfortunately, it has low visibility because of low marketing. How often do you see someone to come into your clinic with, the guidelines of NICE compared to, say, the guidelines of other associations? If you look at the ADA guidelines, now I just need to make a statement here that I admire the ADA in so many ways. I spent 3 years being sponsored by the ADA at the time. I worked at the Mayo Clinic many years ago. But I feel that in the drug scheme situation, there's a conflict of interest. You need to be familiar with the ethical code of the American Academy of Medicine, ethical code, conflict of interest. Intellectual, in other words, if you have a drug-sponsored, if you're involved in the drug-sponsored study, then you're not allowed to vote and you're not allowed to be an author on the document. If you have financial stocks, you sell and share in diabetes company drugs, you must be banned from the committee unless you sell your shares and you have no connection anymore, no financial interest. And the third point here, at least one person, one chairperson should be, should have no conflict of interest. Unfortunately, all three rules here have been breached. So it's not the issue of science here. Something that I didn't kind of realize until recently is that, because we tend to synonymously use the word consensus with guidelines, and they're not the same. If you want to develop proper guidelines and truly authentically based, evidence-based clinical guidelines, you need to apply something called GRADE. I don't know if there's other things, methods that you use or not, to rate the quality and certainty of the scientific data and clinical recommendations behind these data, high, moderate, low. grade method determines the strength of recommendation, strong, weak, and ensures all interests are taken into account, the physician, the patient, the policymakers. And the good news, in my opinion, is that diabetes guidelines based on grade are underway. I don't know if they're published. I am aware of that. Efforts are being made and highly recommended. And I don't even know what the outcome. Unfortunately for the ADA, for example, there's no formal guidelines yet, only consistent statement based on KOLs, key opinion leaders, who are obviously running, many of them, drug trials. So any set of guidelines, I like the statement by a colleague who is an expert in evidence-based medicine. I like her statement here as being evidence-based. It's a buzzword, a cliche. You can only tell when you review the methodology. That's what I'm saying, because sometimes you see a consistent statement and you think it's the best scientific evidence. It's not. You need to review, or if you're aware that they've done it properly, then you're great, that's fine. Otherwise, you can still look at the AGREE instrument, which is a useful instrument to tell you if the guidelines are good quality or poor quality. And here are a couple of recent articles, recent publications. Here's just the quality, and it's called, I'm not an expert, but it gives you several domains, stakeholder involvement, editorial applicability, editorial independence. And if you look at editorial independence, you can see, and with ACE, it's, and this is published in the Annals of Internal Medicine. And this is not just the only study, but when you see consistent results, and it's really obvious. So I want to summarize this talk. So which diabetes guidelines should you go for? The choice depends on you. Please get the balance right. Human care plus drug intervention. Not drug intervention, drug intervention, drug intervention. Don't put all your eggs in one basket. Please retain your role as a physician. Exercise your privilege, your mission as a doctor. Do not surrender control to algorithms. Consider the background quality and ethics. Don't just look at the glossy part, colors and so on. Look at the visible and invisible authors. P-value stands for patient value, not P under 0.05, for all the things I've said. Be practical and conscious of cost, adherence, culture, don't dismiss your own experience. When the patient walks into your clinic, the patient doesn't ask you, I want these guidelines, ADA guidelines or NICE guidelines. They trust you to pick the right guidelines. So please shop carefully on behalf of your patient. They trust you to do that. Do not just follow the most visible guidelines. In the end, answers to these questions will define the type of practice you do, good or bad. Thank you.
Thank you, Dr. Ahouz, for this lecture. And now the panel is there for the questions, if you have any questions. And I would like to take the opportunity and start first and ask Professor Skyler, with all these beautiful, Professor Skyler, with all these beautiful studies that you showed about how to prevent type 1 diabetes, do you think that there is a hope for our young diabetes, or we have to still look for another hope like a stem cell or any other treatment that may give us more, or better outcome?
Well, I think the thing that people can reach to currently are automated insulin delivery systems. They're markedly improving glucose control in people with type 1 diabetes, and they're available now. and there are several of them that are out there. I think that we are seeing evolving the immunologic approaches to try to interrupt the disease process, and I am hopeful that the Food and Drug Administration in the United States and the European Medical Agency, both of whom are considering the potential approval of teplizumab, an anti-CD3 drug that I showed you, to delay the development of type 1 diabetes. We don't have anything yet that has reached a point where it could be a proven method to intervene at the time of new onset type 1 diabetes, but I think there's a lot of progress being made. And as you mentioned in your question, I think that we're going to see cellular replacement therapies advance. There's clinical trials going on now with both human embryonic stem cells and induced pluripotent stem cells. And I am hopeful that these things will come to fruition as well.
Thank you, Professor. Dr. Mahmoud Zarai, please take over.
Thank you, Dr. Abdelrazak. Now, Professor Skyler, in your expectation and from your experience, if teplizumab is going to be approved, for how long it's going to be used? Because, type 1 disease is very difficult disease, and even automated insulin delivery is very difficult lifestyle and quality of life. So for how long, in your expectation, it will be approved to be used in clinical practice?
Yeah, that's a very good question. The clinical trials for new onset diabetes, people who have the disease, one will use it for either 1 or 2 courses, and the course is only 12 to 14 days. So they'll use it at the time they develop the disease, and then a year later, and then hopefully the effects will persist for 5 or 6 or more years. But, you can't keep going back and giving a course of drug like that over a period of time. I think we're going to need to have better and additional interventions and not just rely on that.
Thank you. My question to Dr. Thamer Al-Isa, you really touched a very important point in your talk, which is the inertia on the physician, on the patient, and this has been going on for quite a long time. How we can tackle that? What's the practical approach in your experience, or what you suggest to really lessen this inertia?
Thank you for the question. I think the most important thing is to mention what patients can run into complications if delay of diabetes control is actually happening. There are several data showing increase in the outcome of MACE in patients who are delaying their intensification of therapy, plus deterioration of some of their kidney functions. So I think we need to stress on the medical community that delaying intensification of therapy, keeping patients on higher levels of HbA1c, can put patients at risk of developing complications. The therapies are available, and probably accessible in a lot of areas, and there is no point of waiting and delaying the intensification.
Okay.
There is a question from Dr. Ahmed Sajwani. I believe it is to Dr. Thamer Al-Isa. Says, how do we explain no all mortality benefits with SGLT2 inhibitors when commonest conditions of death among diabetics were tackled and reduced? Are we missing something?
Well, the trials of SGLT2 is the enrolled patients are different in the several of the cardiovascular outcome trials with SGLT2s. There are some trials which enroll patients with very high risk who had cardiovascular events. The DECLARE is actually the trial which has the least or the more patients with as a primary prevention of cardiovascular disease. It seems like from the meta-analysis of these data is that the worse the complications of the patient and the worse cardiovascular status of the patient, the improved mortality happens in these patients. But if you are talking about SGLT2 in whole population of diabetics, probably that's going to be challenging to show mortality benefit.
I would like to ask Professor Skyler another question. It said in stage 3, which is the newly diagnosed type 1 diabetes, how long this stage 3 will go on? I mean, these young patients, to how many years or how many months they can still be considered stage 3, and they be hope or treating them, by immunotherapy, or this can be done even, years after the diagnosis?
Well, that's a very good question, Dr. Madani. The whole thing is that immune intervention will only work if there are beta cells that are still surviving. And there is a big decline in beta cell function from the time of diagnosis over the first year. Then it slows, and there's a more slow decline over the next several years. And what we don't know, because there have been no studies, is whether intervening out after 6 months or a year or 2 years, that we could still preserve beta cell function. There are a couple of trials that are planned at the moment that will take people between 6 months and 2 years to see whether or not one can intervene at that point in time. But I can't. One can't be assured of that. And so you really get to what should be called stage 4, where you get beyond the period of time where one can effectively plan to intervene. But if one has preserved beta cell function, one could go ahead and try, but there's not a lot of trials that are enrolling those kinds of people at the moment.
Thank you, Professor. I think if there is no more questions, I would like here to thank our speakers and to thank my co-chairman, Dr. Mahmoud Zar'i, and thank all of you.